You see that? Perfect. All right. So I thought I'd be remiss if I didn't mention, of course, a lot of what we're talking about with telehealth has been changed by the pandemic. And this just gives you a quick snapshot, very recent snapshot as of May 3rd, so only a couple of weeks ago, of where we're at. And although thankfully you can see here that the pace of deaths has slowed, that's a lot. Better than it was. There are still nationally hundreds of people dying every day. I think we lose sight of that. So I just want to point out it's not gone. It's just, as you know, was just announced. Oops, hello. I don't know what just happened. Give me a second here. Can you see my slide still?
We can.
Okay, my screen went somewhere else. Anyway, let me try it this way. So during that pandemic, telehealth jumped, especially early in the pandemic. This happens to be Medicare enrollees, but Medicare, Medicaid services, CMMS. So, I mean, it's really something that has become huge, and you all know it in your practices. And now there's a lot of consternation about what's going to remain, what's going to go away. The positive message, really, by the end of this is, I don't think it's all going to roll backwards. I think we're going to see a lot retention of the ability to do telehealth when that's really necessary and perhaps the best approach. So they did officially, as you know, end, this is very timely for this talk, they did end the PHE, public health emergency. I've seen PHE everywhere, and I'm not sure that everyone really knows what that is, but it's federal government. And just like my county government, it's a lot of acronyms. So PHE is the public health emergency, which has officially ended as of May 11th. And I'm going to focus on telehealth, but just as a quick comment, a lot of things are being looked at right now. What's going to change? For example, some of the rules that were relaxed basically for Medicaid mean that something like 15 million people on Medicaid may lose their Medicaid. And about half of those, it's because of paperwork. So that'll get resolved because they just don't know what to do. And we and our agencies and stuff will have to help them get back enrolled. And others are because of the way the rules will have gone back to being more restrictive. That's a big negative. Obviously, if you don't have Medicaid and you were eligible for Medicaid, the net result of that is you're going to come in only for emergency or tertiary care. And that's never the right time to come in, even though that's probably what our country is best at. We need to be a lot better at primary and secondary prevention and not so much at this tertiary business. So the other thing I wanted to mention was, I went looking for one, and National Council for Wellbeing used to be National Council for Behavioral Health, I think, that changed their name in the last couple of years. I actually just went to their meeting in Los Angeles a couple of weeks ago. And they have really become the experts on, if you haven't heard of them, mental health first aid. They are truly the experts now on the certified CCBHC, certified behavioral health clinics. And that, I believe, and that probably is another topic, by the way, we should do. Maybe CSS can do it because they are, in fact, in their planning grant mode right now, planning the CCBHC, at least in Summit. There's others around the state. The state is still working to build a committee to look at how they're going to run CCBHC stuff. I believe, based on this meeting I would just add, this is truly going to be the next way that all mental health care is paid for. This is not a mild, oh, maybe we'll do it, maybe we won't. This is it. So I'm pretty clear to me that anyone who's not on board with this, any agency that doesn't work with this, or at least collaborate with a CCBHC, is probably literally 20 years from now not going to exist, maybe less, maybe faster. So that's probably a worthwhile topic at some point. So what did the National Council find? Again, they have huge fingers across the country now. They've been around a lot of years. So they found, you won't be surprised by these, that telebehavioral health did increase access to and retention in care. That's huge. We just had a meeting of our Northeast Ohio Psychiatric Association last evening. This came up. Who's doing telehealth? Who's not? We got private practitioners as well in that group. So we were having a really good conversation about what percentage they're doing telehealth. Seem to range from 40 to 60% still are doing that because their patients prefer it. Even though the psychiatrists themselves and their teams are in the office, they're doing telebehavioral health too. the individuals in their homes. So that's important to know. That it actually mitigated, which is another big topic nowadays, this issue around healthcare disparity. It actually helped decrease that gap in healthcare equity. And that's huge. And doing what I do at the ADM board, we focus on individuals with lower income, who are either uninsured or underinsured, et cetera. And we do a lot of focus now on diversity, equity, inclusion, and belonging, which is the new letter that makes it really real, DEIB. So audio only was a huge boon. Not everybody can afford. You can imagine lower income, they can't necessarily afford a phone. Although many do, they do find ways, and I've heard of Obama phones and all that sort of thing, but those don't do everything you need to do. They don't have that much data time and so forth. So this made a huge difference in terms of getting people connections. And what I thought was striking, those who are not as fluent in English, because if you can do it through a phone system, you can set up translation services within that system, which are not as easy to accomplish sitting in the office, actually, with a person in the room. So this actually turned out to be a boon for trying to help the many people in our country who don't have English as a first language. The clinical tools, you've all heard about these that got ramped up, whether they were apps on the phone or other apps that came through the computer, really did make a big difference. A lot of places with Epic were using Epic eventually as the platform to connect, making it more HIPAA proof and so forth. But as you know, a lot of the HIPAA stuff was also relaxed. So you could use FaceTime, for example, where normally that wouldn't be officially HIPAA savvy. Again, probably hard to break into. It's probably very protective anyway, but because I don't know how you break into FaceTime, but I'm sure some 15-year-old can figure it out. But the bottom line is that also got relaxed so we could actually quickly keep people in care or gain them in care. So there are now threats that still have existed throughout this in terms of scaling that smaller organizations didn't have the money to create the infrastructure to do this very well. They often had to default to their own personal cell phones, which the staff had, and they would have to use those. And of course, now we have the huge workforce shortage issues that have been going on. So that's another big issue. So I'm going to do these kind of backwards on the dates because I think they make sense, and then I'll come to the present. A lot of changes have taken place just in 2023. I'm going to mention those. I'll talk a little bit about 2022, but just really today to talk about where we're at, because that takes enough time, I think, for our short didactic. So this is Ohio Administrative Code, OAC is Administrative Code. I'm also going to talk about Ohio Revised Code, which is our legal codes. So each healthcare professional, this is the state saying that each of our boards, all of us, with our, again, congrats to Amy, now your board for social work for LSW. So here you go. Now it's relevant for you quickly. And that's great. Congratulations again. So these boards are told by the Ohio Administrative Code, you will, you shall, that's about as strong as it gets in law as far as a term of art, you shall permit a healthcare professional to provide services through telehealth, right? So they said, you will do this. You have to make this option available. That's a high bar, again, for sometimes private practitioners, sometimes for smaller organizations in particular. And the big issue here is the goal is to get, and this gets into legal stuff again, standard of care. So you're aware that in the United States, we now have what's considered to be a national standard of care. You go back 30 or 40 years ago, there was more of a local standard of care because some areas, especially the urban centers, had much higher opportunity for medical devices and things for better standards of care, and rural did not. And so in legal cases and malpractice cases, they would talk about that local standard of care. That's gone. It's all a national standard of care. Doesn't matter where you are in the United States. You're expected to have the same standard of care as that physician or clinician providing the care. So the goal is to make the telehealth, either phone or video version, to be equal to the standard of care. And so that's a big issue. It did allow, or does allow, boards to require an initial in-person visit for Schedule 2, and I'm going to show you Schedule 2 again, but really Schedule 2, the reason that's getting the focus is the opiate epidemic, right? So Schedule 2 includes our narcotics, our opiates, our opioids, and obviously the man-made versions of those. So that is really why you're going to see Schedule 2 focused. I'm going to show you a slide that has all of 2 through 4 on it, just so you've seen kind of where that is. And I'll show you the breakdown real fast at the end in my couple of summary slides around the schedule, because I'm not sure everybody understands the DEA schedule, just as a final kind of comment there. So so that is again, this is Ohio Administrative Code saying what they will do, except that initial visit, except that the boards will not require the in-person visit if the person medical record says they're already getting hospice or palliative care. So we're not, quite frankly, at that point, all that worried about substance use disorder, right? They're not doing well. They might be heading toward death. And that's kind of the rule of getting into those types of care. Although some people, thankfully, do get better and come out of hospice and go on with their lives. That's more and more occurring now than it ever did. But that's the rule. Also notice that if it's MAT, right? So if it's Suboxone, they don't name the drug in the law. I think the only drug, by the way, in all of Ohio law is Vivitrol. And the reason for that is that company, Alkermes, is about 1.5 miles from the State House. So I suspect they managed to have the clout to get in, but I think that's the only drug that's actually named by name in the law that way. So if it's MAT, so opiate use disorder, opioid use disorder, or if there's a mental health condition, so you really need this drug, right? We're trying not to discriminate. And in fact, this case, we're helping to make sure that our patients collectively on this Zoom call here can get the care they need. And of course, an emergency, right? So they've got to be seen. There's no way you're going to be able to see them for your schedule, or there's no way for them to get in based on their schedule or the logistics. That's an issue. So you're allowed to not. So this tells you what the boards had to write. And by and large, as I look through it, the boards are pretty darn consistent. So I'm going to show you the state medical board, but the other boards seem to all be on the same page, literally and figuratively with this. I do want to mention marijuana real fast, because I know it would come up somewhere. So officially at the federal level, marijuana is still Schedule 1. It is still not something that's legal, which gets into all sorts of issues with states where they have legalized it, or Ohio, medical marijuana. And so in Ohio law, medical marijuana has been subject to Schedule 2 rules in terms, because obviously they are able to recommend it, and it gets given to people through the dispensaries. But Schedule 2 isn't being used for marijuana for this law. Interesting, right? So it is not so legal that they want to allow that exception for medical marijuana. They do focus on opiates. So just be aware that I think that's an interesting nuance that I'm sure plays into those who are the ones who are recommending medical marijuana, which is not today's talk, but I'm sure there's nuances there that I'm not able to tell you today. Okay, so then we get to the law. So you've got the administrative code, and then you've got the actual law. And the law, if it's in the law, that means it's subject to interpretation by the judicial branch, right? So you've got legislators, the legislative branch makes a law, and then of course it usually gets signed by the executive branch, so the governor. Then it ends up in the Ohio Revised Code, and the only way this gets tested is through interpretation by the legislative branch. That's the judges in the court system. So right now, this is where we are and it's not been tested. It's too new, I think, to be tested in a court case. I couldn't find any when I did a quick search. So the healthcare professional can use synchronous or asynchronous technology. And asynchronous means you could potentially do some information back and forth on email, texting, MyChart, right? If you've got Epic or any of those similar kind of platforms. So they're allowing for all of that still, because you need to be able to communicate. And sometimes that's the only way you're going to get back and forth communication between a very busy clinician and potentially a very busy patient. So they allow for this asynchronous, but synchronous would mean real time talking right now with the person, or actually on video with the person. And of course, the highest level of synchronous is sitting in the room together. But technology wise, we're talking about telehealth here. So the initial visits can in fact still be, based on this, a virtual visit. The annual visit, number 4 there, also can be a virtual visit. The healthcare professional, number 2, I think this is important, can deny telehealth services for an individual patient and require them to come in for an in-person visit. Why might you do this? Well, if you're doing substance use disorder treatment and they never show up to drop their urine, because that still has to happen, they don't have to do that synchronously at your appointment, but they've got to do it. It's something you say, look, somewhere in the next 2 months, I need you to go drop, right? Here's all the places you can go. And then you need to do that. But if you come to the visit appointment and even if it's a virtual, like, you didn't do it. Well, and this came up, and like, well, you had 60 days. So I get things come up, but you could have done it any of those days and it would have taken you, including bus travel, 2 hours. So I have to have you come into the next visit in person, and you will drop that, right? So that you can see how that because that's my law, right? I have rules around me as a prescriber, even for Suboxone. And others of you who would do prescribing. And the net result is, if at some point I'm going to say, you know what, I can't just persist in letting you not show up. I need to see you. I need to get your drug screen. I need to make sure you're okay. Maybe you do need a physical. You used to do skin popping, and I want to make sure your skin's healing, right? There's a lot of reasons you may need to actually see the person in person. So this allows, the laws allow that a clinician to do that, or a board to then allow their clinicians to do that. If you are providing telehealth services using this Ohio Revised Code 4743, then you also have to comply with any of the state and federal law, right? So around patient protection. So this is the whole HIPAA, relaxing HIPAA not. So they built this in effect with wiggle room, right? So if the feds alter how they allow us to skirt HIPAA a bit, as they did during the pandemic, then we can go with that. Or if they do that, but Ohio says, nope, we're not letting you skirt that, because the states can be more restrictive to protect privacy, not less restrictive than federal. That's always how laws of any type work, but that's the example here for healthcare. So you have to be careful and make sure you know exactly what your board says, which is really what the state's saying. And here's state law giving that wiggle room to the boards, basically, to set that up. Okay, I know it's a lot of words, but so and then in terms of the physician or physician assistant, this is in this law, but it really applies then more to the medical board. But I think the other boards, as far as I can tell, look pretty similar to this. What if you've got a patient who while you were treating them, especially during the pandemic, and they moved to Pennsylvania, just to make it simple, easy move, not far from where some of you live, not far from Neomed for that matter, right? So the patient's there. Can you still provide telehealth services to them? And the answer does allow you to be able to do that, again, as long as that meets these 4 items here. And I think that's important. Also allows medical devices for glucose monitoring, heart rate. So again, it's not all about behavioral health. This is telehealth for all clinicians. The other thing is, and I thought this was good as a forensic psychiatrist, I didn't know this till I did this talk preparation. When the patient is consented to having their care by telehealth, they can't later file some claim that, oh, you didn't give me the care that I would have gotten if I had shown up. Because otherwise you get, oh, I didn't drop my urine. I would have done that if I came in person, right? You don't want to get into the lawsuits over really minutia like that. So they did protect us all with it, which I thought was very important. So here's the state medical board. I think this is interesting because they basically anticipated the law that went into effect that I just walked through on April 6th. Obviously, they're all talking in the background, waiting for the legislature. So this went into effect actually at the end of February, but it expanded telehealth, right? Here we are. I'm going to tell you about the feds. They may start to decrease telehealth flexibility, but at the moment, our state has still been in this expansion mode really expanding on what happened in March 2022. Right, so they're expanding on these laws, saying, wait a minute, this has been helpful, like that National Council survey. This has been good in many cases, probably not great for everybody, but very good for a lot of patients, families, in terms of transport and all that support they need to give, and us as clinicians. This has made it better. And in fact, the other discussion last night at NEOPA was no-show rates dropped a lot, right? Because if the person didn't show up to their appointment, you could call them and say, hey, you know, we're supposed to start your appointment 7 minutes ago. Oh, I'm sorry, let me get on now. And then they pop on the video if they had video, whatever. And so some of you, I'm sure, have experienced that. That's a win. That's good for both people in that therapeutic alliance. So it's good. So this was March of 2022, again, looking at the law as well as the administrative code, because they're kind of merged together here. And you'll see here, it's very similar. So I'm not going to review all this in detail again, because it's very similar to this. And I highlighted, the bolding is on me, not in the law itself, but the standard of care issue still needs to be there. You've got to be able to, and that means you as the clinician have to feel comfortable that you're not leaving too much room for errors that wouldn't have occurred if they were in the room with you, right? And some of that is why some clinicians, even now, never have done virtual health, telehealth. They have stuck with in-person the entire pandemic, taking the risk, if you will, of infection, often sitting, more like 10 feet apart, patients at the back of the room, you're at the front of the room, you're both wearing masks, and they've done that, and many have done that successfully and not gotten COVID. And that's because they felt like they weren't sure the standard of care would be met. Having said that, of course, those are really outliers, because many organizations forced telehealth actually in the beginning of the pandemic, and clearly people have been getting care. And I've not seen any lawsuits so far indicating somebody trying in any state, because not every state has our language, saying that someone's suing because they didn't get the care they should have gotten. Because almost always the patient and their families are pretty happy with the idea they can do it without driving there, paying for parking, all that extra time, or hopping 2 buses, which some individuals do, and so forth. You can see where this would improve adherence to times for appointments. It just makes more sense. Okay, so let me mention controlled substances. This is where it gets a little bit different and where the laws may change. And this is the ones where people are very concerned. Of course, again, on the ongoing opiate epidemic, which is, although we don't talk about it as much, the deaths are still bad across the country and across the counties in Ohio that I've seen. Summit County is basically plateaued, but we aren't going down like we had been, which is a problem. So it's way too many people dying, well over 200 a year dying in our county, and across the state it's thousands. So there's a lot. That's why you're seeing all this focus through the administrative code and the revised code. So this says that they must do, you'll see how the laws are written, they must do physical examination for Schedule 2. We're really talking opiates mostly, but it gets into amphetamines as well, except when the medical record says they're in this hospice failure. You can see how this all dovetails, all pretty similar. MAT, medication assisted treatment, mental health condition. So maybe they really need Ambien, although that's actually not Schedule 2, that would be 4. But if they really need Ambien for sleep, you can do this. You don't have to bring them in for that as another controlled substance. And again, marijuana was excluded from this because they're considering that Schedule 1 for these purposes. So it sounds like however you do, I don't know enough about medical marijuana recommending. I still refer to it as so-called medical marijuana until we get more research. So, and then of course, there's always an emergency exception. Now, this is where you start to get into what's currently going on. B at the bottom, 4B says, after the emergency situation ends, May 11th, it ended, you must conduct a physical examination to continue prescribing the drug, right? So now you've got this starting to see, how is this possibly going to change? Unless, you'll notice number 5 gives us federal law, right? So federal law says you can do it, then Ohio is going to go with it. So they're giving that because the law, you can't get the law written exactly at the moment that the feds come out with their new laws and so forth. So that's why we're seeing these changes. So May 12th, the day after May 11th, the federal law did extend the flexibilities for telehealth. Therefore, based on what I just showed you in Ohio, they're also extended because that was already written into our law from April. That any practitioner, this is interesting, this is worth paying attention to. If you have a relationship with a patient, therapeutic alliance, whatever word you prefer, that you establish before November 11th, so Veterans Day of this year that we're still in, then you can have a year of grace period. Basically, this is buying the feds time to work on what I'll show you next, as far as a possible permanent law. If you currently are seeing somebody, you still have until November 11th of 2024. So this just gives you the end deadline. If you see somebody November 12th of 2023, you will not be in this grace period. I think that's going to get weird. And I think I've seen a lot of, apparently the federal government, this is HHS and SAMHSA and DEA kind of all working on this together. Well, SAMHSA and DEA are under HHS, Health and Human Services. So there's a lot of discussion, a lot of public comments came in during the comment period, which I think has ended at this point, about this. So we may see this change, but just be aware of this, the patients, if you've already got them and you're seeing them, then you're in good shape. In terms of controlled medications, if you see somebody late at the end of this calendar year, pay attention to the law because it'll probably change, is my honest opinion on that, to account for that. But right now they wrote it in an interesting way, just to kind of show that you'll have up to a year if you see them by Veterans Day of 2023. So the flexibility continues, and here's where I'm going to get into the Schedule 2 and 3 and 4. No in-person requirement for any of those, 2 through 4. If you do audio, video, telemedicine encounters, no in-person for 3 or 4 if it's audio only. So what does that say? That says that if you're doing Schedule 2, it has to be audio video. It can't be phone. That's what they're saying in this. So it's flexible, but it's not quite as flexible as it might have been, right? So there is this issue around opiates, around Suboxone included in that. And the DEA will still allow you, if you're an Ohio prescriber and you're using controlled substance on your DEA license and your patient moves to Pennsylvania, you can still do that. So they left that flexibility in place. So that mostly they've extended the flexibility to make sure that we're not leaving putting any patients in harm's way. That's a win. So at the same time that was going on, CMS was working on what to do about Medicare. So all the way through the public health emergency, which again officially has ended, all the way through that emergency, Medicare has had somewhat different rules, very similar, but somewhat different. So you'll see here that they actually had already passed, even before the May 12th extension, this Consolidated Appropriations Act. It's already extended Medicare telehealth telehealth for prescribers working with patients who have Medicare through December 31st of 2024. And there's no whenever you start to see them kind of clause in there. So it's actually broader. You'll also see here that apparently the accountable care organizations have a good lobby because they are going to have an ability to continue to offer telehealth services after December 31st, 2024. That's obviously a carrot to organizations right now to work on being an accountable care organization before January 1 of 2025. I mean, it's in there. It's interesting because it's kind of embedded. So that obviously was part of the discussions that went on before this was put into place. But some of their flexibilities, this gets into the HIPAA business, some of the flexibilities are going to disappear. So FaceTime, Facebook Messenger app, WhatsApp, none of which are secure officially, it's going to be gradual. It's not today. It's going to be gradual. Those relaxations are going to go away. So in order to do, let's take it to the quick, schedule, to do the scheduled substance, controlled substances, you're gonna have to move to a HIPAA compliant platform. I'll give you an example of WhatsApp from another forensic arena. So in a meeting with law enforcement, 2 Novembers ago, we were talking about a program called Street Smart, which is very secure. And one of the officers kind of let the cat out of the bag that a lot of officers in the background are communicating about individuals they encounter on the street with WhatsApp, unrelated to the pandemic. And there was a big, because a lot of their leadership was in the room. So WhatsApp, I know that one only, I've never used it, but I know a lot of clinicians use that as well. That is not going to count for this. And since it's not counting for Medicare, I suspect, because I didn't see any language about this in the other laws I showed you, I suspect that's the way this is going to go. They're going to want HIPAA compliant platforms, but as we move forward, perhaps, and I'll show you more of that in a second here, perhaps we'll end up with continued flexibility. So here's a quick summary slides. These may be easier for you. I got these from the APA, my association, and some of yours. So you'll see here, PHE ending May 11. We already talked about all this. I think everything on here I've already said, so I won't be redundant, but it's a nice visual of how this is going to be, what's extended or made permanent. So there will be some that will become possibly permanent. They're working on that law now. The draft one came out for public comment. And of course, I told you about the May 12th one that did put into place things like this November 11 of 2024 time frame. And then Medicare is got some things that revert back, but they've pretty well retained things until December 31st of 2024. All good news. Here's that journey that I reviewed. In case you like visual, I want to throw these at the end, but time's sake, I won't review them again. But this gives you a sense of all that. The 6-month time frame in terms of some flexibilities for new patients, and then you see the full year there for anybody prior to November 11th of 2023 that were on your caseload, and then obviously moving forward. This is what I've told you about the controlled substances as well, the similar, just a summary, but I think it worked out nicely. Notice that they got 38,000 comments about all of this, especially around buprenorphine, right? So Suboxone being buprenorphine plus naloxone or Narcan. So that they got a lot of comment from a lot of individuals who do that work. I know Dr. Robbins does that work. Some of you do that work. A lot of commentary on what do we do around MAT, because again, we're very much in this country, we really have adopted pretty broadly a harm reduction model, and we don't want to be taking away people's Suboxone needlessly. That's just not a recipe for good outcomes, while we're still trying to figure out how to roll back and further decrease overdose deaths. Okay, so then the other one here, by the way, is this Ryan Hate Act. I hadn't commented on it before. Another reason I put this slide on here. That if you've seen a person at least once, even pre-pandemic, you will have some, right now, DEA is interpreting this, you can still continue to do that, not in person, and maybe forever. That's going to be discussed in the final law, which will be my next slide, which is the last one. So just so you've seen it, this is the schedule from the DEA, pulled from the DEA. It shows you what the various schedules. So you'll see why everything's focused on 2. These are the considered to be the highest potential for abuse. Now we'll say use disorders. And so that's the big group you see. And most of us see that as opiates or opioids and stimulants. So that's really that group that we talk about. Something like cocaine is on there because like plastic surgeons will use this to numb a nose before nose plastic surgery kind of thing. So that's why you see it, that most of us are not giving out any Schedule 2 cocaine to our patients. And then you'll see that other things remain up here on Schedule 1, including marijuana, right? So that gets into those issues. And then beyond that, less control, but still controlled. Those of us who have a DEA license, it tends to say 2 through 5, right? We can do all of these substances. We don't You don't ask to be only a Schedule II doctor or only a Schedule II psychiatric nurse practitioner or something like that. So anyway, that just gives you a sense of these other substances, Schedule IV being very common for some of our psychiatric medications as far as anxiety and sleep type things. So here's the potential permanent law. And again, this is a real quick summary because there's a lot of discussion ongoing. This is far from the permanent law. So they are looking to come up with a narrow list of telemedicine exceptions, not quite what we have now. Some of the legacy standards will remain unaffected. The telemedicine prescriptions gets back into this whole issue about working together with another clinician. Is there physical examination? Maybe somebody else did the physical. So you're not saying I have to do the physical, but maybe Amy Lackritz does the physical on an 18-year-old, since I don't normally treat youth, but she would see an 18-year-old. She does the physical, but I'm going to do controlled substances. That can count, right? So I know there's a physical. I'm aware of the physical. I know that it was okay. That can work. So they're trying to work on how do we, as a team, make all of this work. So I like that. I think that's very thoughtful. They're not only focused on those of us who work in the substance use space. So that's good news. The no prior exam piece, again, same idea. Notice 30-day supply. So now we're getting into, wait a minute, how does that, but that's different than what we have right now. And also that this one does not have opiates involved, Schedule II. So again, this is getting a lot of public comment as we speak, because this is not done. This is a law to come at some point. And that's where the 6-month extension is on there, which is what I showed you on that APA slide. So here's where I pulled some of this information. Those of you who like to look it up, or if you can't sleep tonight, I recommend any of these sites. So Ohio Revised Code, by the way, you can literally Google ORC and any code number, in this case, the 4743.09, it comes up, it's free, and you get the actual text of the law. It's a very user-friendly type platform. The one you mostly hear about us talk about here is 5122, 5122, which is the mental health section of the Ohio Revised Code. So when you're looking at like pink slips and civil commitment, all that, that's all under 5122. This is different, the 4743. Under the Medical Board of Ohio, they have a nice telehealth guidance section. Other boards may have it, but the one at the medical board is particularly robust. So that may be of use to you. And then going to the federal level, I gave you 2 statewide, and this is the federal level, telehealth.health and human services, hhs.gov, also a great site. And there's a lot on there, and you'll get it. It'll be updated as they get closer to a final permanent law, which based on what we've seen, probably won't go into effect until on or about November 12th of 2024. That seems to be what they're targeting based on the current law that extended things through Veterans Day of 2024. So that was a mouthful. That's how you can reach me if I completely confused you. And we can take questions. Thank you.